Okay, good afternoon. I'm Bo-Göran Ericzon, Professor of Transplantation Surgery at Karolinska here in Stockholm. We all know that without organ donation there will be no organ transplantation. Although organ donation has improved globally, I would say, and in Sweden also specifically, also transplantation and the results after transplantation has improved. We are transplanting patients that are older, sometimes sicker than before. So this discrepancy between the organs available and the number of transplants we can perform is still there. And we have to remember that transplantation is slightly different from many other healthcare systems. Normally, if I have a patient sitting in front of me with a cancer, we can offer this patient treatment even if the chance to cure is maybe less than 10%. This is not the case in transplantation. For each transplant we perform, we also have to think about the group of patients on the waiting list that might have a negative outcome because we are using organs too liberally. So the discrepancy between the available organs and the number of transplants we do are much larger than what we see when we compare waiting lists with transplantation. Over a half an hour or so, we are going to focus and maybe brainstorming what can we do to improve organ donation. And we have a fantastic groups of panelists here that you have met before during the day today. Where did I put my paper? I need that. Stratos, you came back on video. We have met you before, so I think they are familiar with you. The same with Luciano Potena, the president of ESOT. I met you before here. Andreas Zuckermann, the same. And Johan, you just performed here. But we also have a person with personal experience of transplantation. Aiste Staraite, the chair, Global Heart Hub, Patient Heart Failure Council. You are from Lithuania. And also Lisa Selberg, the president of the HCMA in United States. And I think I would like to ask you, maybe start with Johan, what would you think would be a way forward? We have heard today about how we can maybe use more organs in different ways, but what would be your way of improving organ donation and increase the possibility to do more transplants for our patients on the waiting list?
I think, as I mentioned, in my area, we do not use all organs. I mean, we declined a lot of them. And if we could be better to see which of the donated heart we actually can use in the best way, I think just that could increase the number.
Are we too afraid of using organs? Are we afraid of what the result would be?
Yeah, I think that because somebody tells me, but it shouldn't be so difficult. But it is actually in the middle of the night, and you have one single doctor who should decide, and they think about the patient, of course, but also maybe the results or other things, the resources. If you have a better support system that could say, I think this organ will be good, maybe not tomorrow, but within 1 week or 2 weeks, or maybe we know if you prepare like this, you put it on ECMO directly after the transplantation, you improve the quality or something like that. I think that we do it already today, but we could improve this kind of...
So is that related to how we look at the outcome and compare between different centers? I mean, would you, if you didn't have to compare what you're doing, would you be more liberal in accepting donor organs?
I don't think I would. I do not think like that when I, in the middle of the night, decided. It's more. I'm afraid for the patient. I mean, if you have a very sick patient, which maybe is in the intensive care unit today, and this is the only way to save the life, then you're more. You lower and accept. But if you have a patient actually who's maybe feel quite well, maybe have been on the waiting list just for maybe 2 or 3 months, and you're not sure, you think it could be very good, but there is something who says this could end up.
Mm-hmm.
But and I think maybe if you have the possibility to discuss it, then of course you can take a more team decision, and that's always better. But sometimes you do not have this maybe senior surgeon or something like that who has a lot of experience. So I think if you have a system which could help you, and maybe especially for younger doctors who has not the long experience, that the average amount of transplantation could increase, and you could lower the decline rate.
Andreas, when we look at outcome after transplantation, do we sometimes forget the patient on the waiting list? And should we report much more intention to treat, to look at the results once a patient is accepted to the waiting list? Because for the patient, the decision is taken when you are on the waiting list. They consider also that time as part of the what chance they have to get a new life. What do you think? Are we too focused on post-transplant outcome, and will that hamper the way we act in practice?
Partially, absolute. I think that the balance, we have to balance the risk of a patient dying on the waiting list versus the risk of a patient dying due to an early complication. This is what we are struggling with. And you're absolutely right. I think this has to be part of the calculation. There has been some 10, 15 years ago or so, there was a very nice paper on if more organs are accepted, even with a higher risk, tackling the death on the waiting list, and they found out, well, if you do more transplants, even accepting higher risk donors, you might in the end have a better outcome, losing less patients on the waiting list. However, now over the last 10, 15 years, the landscape has changed in heart transplantation, not so much in liver transplantation, not so much in lung transplantation, because we have very good devices that we can implant patients so they survive for a longer time on the waiting list, or even help patients who have relative contraindications that might change over the next months or years and make them candidates. So the landscape had a little bit changed, but I think every surgeon, when he's called in bed at 3 a.m. with a potential organ offer, says, okay, the balance with, do we have a risk of a patient dying on the waiting list versus a risk of losing potentially a patient after transplant? In my region where I live, Eurotransplant, more than 70% of the hearts are accepted. And we just did a big analysis comparing Eurotransplant to US data, and we are significantly accepting more hearts than in the US, significantly more. But we have a complete different donor population, so we exaggerated and said, okay, how many more transplants could you do if you would do the same philosophy in the USA? But in the USA, we have very strict quality, which only measures post-transplant outcome and not pre-transplant mortality on the waiting list. So this is, and if you ask me the same question as Johan, I think we need better technologies to preserve hearts, even borderline hearts, so we can easily and go do these transplants with the same success as with perfect donors that do not have any risk factors.
But the fact then that you have this lifeline or this artificial support, wouldn't that be an argument for being more brave and accepting more marginal heart donors? Because you can actually You don't need to have immediate function as many years back. I mean, because we've seen in most of the organs, they're by time, people tend to accept more and more marginal, so-called marginal donors. And wouldn't that be a good reason to increase the number of acceptance for heart transplantation?
Could be. Yes, could be. I think you need to give the surgeons some safety net that they feel safe. It's a lot of perception. Just an easy calculation. We analyzed donor hearts above 60 years of age for hearts. If there is no coronary angiogram done in these donors to see if the coronaries have problems, only about 10% of the hearts are accepted. Mm-hmm. If you have a diagnosis with a coronary angiogram showing that the coronaries are fine, about 50% of these hearts are accepted. So, and if we do coronary angiograms, what is the percentage of severe coronary artery disease in these 16 and above donors? I thought it would be 50%, 60%. Actually, 16%. It's very low. So just the perception there might be something, and I sent out a team the whole night. Next day they are away. They cannot work. We lose a lot of money because we sent the plane somewhere back. The hospital kills me for going out everywhere with these high costs. And then I found out, well, the donor had coronary artery disease. So just with simple diagnostic tools, I think we can easily increase the number of transplants, but these have to be implemented in a routine way in all allocation systems, and this is still not the case, not even in Europe.
Lisa, what do you think the patient view on this? Would you think that it's reasonable to be more liberal and be not so critical on the organs, to accept more what we call marginal organs in order to have a larger proportion of the patient transplanted and not dying on the waiting list or not even being accepted to the waiting list?
Tricky question. So first I want to give a perspective. So in 1995, my sister had a cardiac arrest and she became an organ donor. She donated her kidneys and her liver. At that time, I said to myself and to my family, remember what this side feels like, because I have a feeling I'm going to be on the other side someday. And in 2017, I had my heart transplant. So I've got a unique perspective of both sides of this equation. Now, the question that you're posing is, what heart would I expect to get? What quality of heart as a recipient? Obviously, we want high quality standards. We want to understand that we're going to go through this risk and have a really good likelihood of a good heart on the other side. But we don't all have that luxury of waiting for perfection. So I think there needs to be an opportunity for a patient to be part of the shared decision-making in terms of what organs they do receive and they accept. And if we understand that it's got a higher risk of coronary artery disease, or there might be something not quite perfect about the heart, that should be a decision between the individual patient and the physician when the decision is made that there's at least a match. And in the United States, we are given information on high-risk donors, if they're in prison, if they've had any social behaviors that are questionable, drug use, etc., and you can make the decision to accept or decline. And in the recent years, we're even accepting, hepatitis hearts, HIV hearts, and we're opening up the door to deceased donors and more opportunities to get those hearts in. So as the patient is educated through the process of the listing, when they're listed, and what can you expect to learn about, this heart that we're going to be putting in your body. My call came at 12:30 at night, where I was told, age, gender, perfect match, come get it. But there was no risk factors associated with my heart. So I think including the patient early in the process, explaining to them what the options are, if there are options available in that nation, to know what they want for their individual heart. Now globally, I think there's an opportunity to demystify where the risks are And it's very technical data that we're dealing with here, so you have to bring that down to the patient level so they can understand what the risks are and what the outcomes might be. But that's my point of view.
Yeah, that gets us into the other thing, that this information between the healthcare and the patient, and at that acute situation, I mean, would you in general trust the doctor's decision that this is a good organ, or how much would you like to be involved in that? There might be a hepatitis C positive donor, there might be a very old donor, there could be other things, yeah. What do you think about that? Would you like to be involved in all this, or would you just have the profession to choose for you?
I think at that point there are two different types of patients. There are one group of patients who expect the specialists to lead through the process, and they are there participating, listening, and asking the questions. And there is another group of patients where they are actively engaging and having that shared decision-making, where they agree what would be the next steps on the care pathway of what action they can take to improve it and have the best outcomes. So it really depends case by case, and in the global community with the patients, we do see that differences, and it's very difficult to specifically say that, you know, that would be the way. I think it's very individual in terms of the global perspective, in terms of the countries, of the legislations, of the communication, of having the shared decision making, and you know, it's really up to like case by case.
I think it's very important to have this trust between the patient and the doctor and the healthcare at that situation. But sometimes it's very difficult to in detail discuss all these risk factors. But thank you very much for your answer there. Stratos, what do you think? Globally, what should we do to improve organ donation?
Well,
not only in areas where we have no organ donation, but also where it's acceptable today.
Well, I could talk for hours, so I'll try to limit myself. Indeed, on that topic that you were just saying about the selection of the recipients and the quality of the organs, I've had some experience personally when I was working at the national level before coming to WHO. One of the heart centers in my country was like selecting the patients to be on the list, selecting the donors, the organs, just to have at the end of the year an absolute close to 100% survival and outcomes, and being placed as the top of the world as a best center or something like that. From the perspective of the stakeholders, so from authority perspective, as I was, we didn't like these practices. The donation professionals, we should not forget them, because they are the ones striving in the ICU to provide these organs. So they are also experts. I mean, they're not just some doctors that are not relevant or knowledgeable about transplantation. So there are anesthesiologists, cardiologists. They would evaluate the same, and they would come up with the proposing that organ as a good, with a good perspective and outcome, and then it's being rejected by the transplant center, and they feel sort of canceling the whole effort that they put in. And this is discouraging for them to give us another donor in the future. Say, you know, we put all that work in. From a society perspective, I mean, our choice as an authority was those organs that were rejected to offer them to another center. Since we didn't have many centers in the country, we would offer them to neighboring countries. And most of the times they would be accepted, because it's an issue of experience and resources of the center. And they would be accepted. And then it would go on the news. Oh, last night a bridge was built between country A, country B. Surgeons came in to take an organ. And then the society, the local society, would say, why are you shifting organs outside of the country, giving them somewhere else? So it created also a negative sense within the community. And then for the patient themselves, having been discouraged, they would seek some point other ways of resources, traveling abroad, going somewhere which is perhaps not the best. We've had patients that have been rejected completely by being waitlisted, and then they would not accept that. They still had hope, and they would go somewhere else where they would offer something without really good quality, and then sometimes they would never come back. So all these are aspects that we need to consider when it comes to the selection and not just the clinical. To answer your actual question, how do we increase? I mean, there's two things. One is increasing the donation rates, of course, and the process within the system of how we get better and more donors. The other thing is, what are the alternatives that we have for organ donation? I suppose they had been mentioned during the day. Where are we now with the research when it comes to artificial organs, biotechnology, xenotransplantation? We've been hearing about decades now about the developments in artificial organs, animal organs. We're always hearing, yes, we're almost there. Still a little bit behind. So I think we need also to strengthen that effort in that area. It would offer a lot of positive and not just hope, but I mean, it would relieve a lot the problem. As the population, the world population is growing older, we will have limitations also in donation and quality of organs donated. So we really need to invest in alternative sources. Until we get there, of course, we need to strive for better coordination, better detection, not wasting the organs. And I mentioned that in my morning session. Wasting the organs means, like, if you have a national system where you have a good donor, which is a multi-organ donor, but then in your country you have only 2 or 3 programs, only kidney and liver, and you don't have a heart or lung program, then you're wasting those organs. You're just going to procure 2 kidneys, and then the rest of it just goes to waste. So we need to strengthen the cooperation between countries in order to utilize whatever is available and not really waste anything. So I'll keep it here. Thank you.
Okay. Yeah. Of course, no organ should be wasted, and we need international collaboration to come closer to using whatever organ we have there. Okay.
Yeah, so in Sweden we have...
Can you get a microphone? Or you come up here?
Okay, so I have a question to the panel, because in Sweden we have the opt-in system, which we heard about today also with Annika Tibell, the problems that it creates for the physician of trying to find out if this patient wanted to donate. But when I was living in Wales, they implemented the opt-out system, and it was a huge information campaign, and you found out, did you not want to donate, that you needed to actively opt out. So do you think, because you're from different countries, what does it look like in your country? And do you think that an opt-out system would improve the number of donors available?
Okay, we passed that. Yeah. But one little comment there, because Annika, you showed on the last part of that when organ donation was not possible, and that was when the will wasn't known and you didn't find a relative to ask, because I think that is what misled you. So why is it like that then, Annika? You need a microphone. Because that sounds like you cannot expect that someone that hasn't said no to organ donation couldn't donate.
I agree with you, Bo-Göran, but the problem is you have an incomplete evaluation and you don't know that this person didn't say no to the relative, the close relative who is up in the mountains and cannot be reached. So I think that was the background. You have an incomplete evaluation of the will of this individual if you can't find the relatives.
Yeah, so then the relatives will have a final...
No, the absence of relatives will have a final say, we can say, but not the relatives. There are always compromises, but still in Sweden we consider that we've had an opt-in system since the old law from 1997, though it was weak because we have this veto right for the close relatives, and that has been taken away.
Speak to the United States. it's a state-by-state basis, and many states have opt-in on your driver's license. You sign the back, you check it, and you can even be organ-specific. I'll give everything, I'll give organs, I'll give eye, bone, tissue. You can check it right off on your driver's license. And with the exception of a family member dissenting, the family member does have the last say in the United States, and we always encourage everybody to tell their family what they want, as well as
if they have a driving license.
On the driver's license, and tell your family, because you can put it on the, families are funny.
Yeah.
Yeah.
What will ESOT do?
ESOT, okay. In opt-in or opt-out, or in
Yeah, you can take that first.
Okay, so I mean, so ESOT cannot take a direct position on the opt-in, opt-out, because I think it's, of course, the opt-out is proven in certain countries to be more effective, and we have, of course, always we take about the example of Spain, but we also know that it's something that has to be embedded in the culture of the country that you are implementing the system, because if there is a culture of solidarity and of donation and of sharing, I think that the opt-out system is working. When there is mistrust towards the healthcare system, when things are not working well, or when there is not a culture for donation, the opt-out system may be dangerous because may arise suspicion in the practices. So this is something that needs to be carefully evaluated. On ESOT side, what a scientific society can do in Europe is to improve and to promote the campaign for donation, and to promote the knowledge and the need to share the value of the donation. So this is something that ESOT can do, and of course this cannot be done by ESOT itself, but it should be done together with the other stakeholders, including patients' organizations, including advocacy group, including governmental agency, and this is something that is relevant for the promotion of the transplantation in general. Last week we went to the European Health Forum in Gastein with this objective to raise the concept of transplantation and the need of transplantation into the European political agenda, and we had a fruitful debate, and hopefully we can see some results out of it, and we are issuing today a manifesto that has the goal to promote equity in access to transplantation through different measures. And of course, the promotion of donation is the first step, because if you don't have the low number of donors you have, the least access you have to that therapy. So that is the first step, but we know that we need other steps, including the education, including the awareness, including the protection of minorities, and a specific subgroup of patients that have lack of access, like the hypersensitized patient. And something that is important also to underscore is the way that the information is delivered regarding the risk, and the information is delivered to the patient. Because I was thinking while you were saying about the risk of the donors that you are disclosed. So if the donor is a prisoner, there is no scientific evidence that the prisoner donors increases the risk of death after transplantation. So, I mean, it's a useless information, is a prejudicial information.
Completely. They also ask if they're gay.
Yeah, and that doesn't mean anything.
Because women aren't prescribed.
So if, I mean, it may be riskier, like a middle-aged white businessman taking drugs without.
Exactly.
So rather than, so that's the point.
We're still living with a lot of the HIV/AIDS technology or thought processes in our policies. We're slowly getting rid of them, but that needs to go in the United States.
Yeah. So beside that is a marker on how the information is disclosed and how the society is thinking, and this is also affecting the way that the patients can have access to transplantation. We heard earlier the mistake in the algorithm that was going to penalize Black patients, and we know also that when this algorithm is not in place, like in UK, there are evidences that people of color have less access to transplantation besides the clinical conditions. So the point here is, what can ESOT do? I think that as a scientific society, we can do the promotion, we can do the advocacy, but also we have to push as much as possible the science that can drive our decision making and support our decision making. For example, what is the risk of a donor, and what is based on scientific evidence, and what is relevant to disclose to the patient. For example, I give you an example about what we can disclose, and this is striking between Europe and US. No, median age of European donors is 48. Okay, median age of heart, I'm talking about heart, of US donor is 30. We know from the registries that if the donor is over 50, you have 50% greater risk of dying during the first year. Not 50, but probably 40. So am I going to disclose to the patient that you are going to receive a donor that is over 50 and you are having a higher risk of death, running the risk that I'm losing half of my donors? Because if I'm saying this to the patient, I'm not sure that many patients will accept that. So the point is that it's challenging to balance this, also to balance this kind of shared information. And I think that the most important thing is to build the trust, and to build the trust between the scientific organization and scientific stakeholders and the patient's organization, and work together towards the access to therapy and the best quality that we can get out of this therapy.
So also how we use the data, because I guess that even if you say over 50 years, there's a continuous 45 and 55. It's not exactly 50, so that's a continuous risk assessment.
It's just an example, just to make it up.
But I think it's very good if ESOT can actually promote research within this area. Gabriel.
Can I just pick up on something?
President-elect.
Can I just speak up on something Luciano said? So you're not going to disclose the age because you're worried about losing your 50%. Surely in a shared decision-making process, you present the options, because you have to talk what the alternative is. And we heard from Lisa, the chances you die on the list. So you need to balance where your risk is and what your appetite is, and how you balance between the options, because you don't know what the next heart will be. There are no perfect organs. They're all second-hand. They're all second-hand, and they come with different baggage.
To challenge a little bit here, we're trying to work on shared decision-making and trust. So by you withholding scientific information that this heart may not last as long, you break trust. You have to trust the patient to help make the decision that's right for that patient. And they have to understand that if they say no to this organ, there's not a guarantee that there's another call coming. And it's a complicated process, and it takes time to educate. And patients can help support patients through the process. I've been there, I've done that, I took that kind of a heart, and I'm here today to talk to you. So I think we're living in an interesting time where the world is opening up and things are easier to find out and patients get data, but we need to have that trusted relationship that we are getting the facts and that we can make good decisions.
I was just give to Andreas and then reply. I was not saying that we don't have to disclose the scientific information. Right. I was just saying that we need to have an appropriate literacy on how we disclose this information.
Agreed.
So that's the point, because it's easy when you have to work on something that has no scientific evidence and then you just say whatever. But when you need to disclose the information in an appropriate way.
We have 1 minute left. I would like to bring one other thing up, because I think when it comes to organization, when it comes to how we treat a broken leg when the patient comes to the hospital, and how we treat organ donation, I think it's very important how the different hospitals take this question and how they organize it. And it was obvious also from what Annika showed that the profession, now I'm sorry, because maybe one of the most important professions that should have been here is the intensivists, because they are the the one that is closest to organ donation. So I think the hospital organization is very important there. And I would like to just ask a final question, because I know that in some countries, like in Finland, the competent authorities actually go to the different donor hospital and see if they live up to what they are supposed to do. Also, I think it happens in Norway. We talked about it in Sweden when we have the meetings together with the competent authorities, but I think there hasn't been resources yet to do it. But I think that could be one important thing, because we know when the competent authorities come to the transplant unit, we try to be as good as we can. And I think that would also be true for the donation hospitals. Do you have that in the final, very short, do you have that kind of system in your countries?
For Austria, yes, but it still has not enough teeth. So they show this hospital, yes, this hospital does not give this amount of, they have an ICU, a neurological, neurosurgical ICU, trauma ICU. So they show it, they calculate it, but they do not have a real impact in saying you have, based on the data, you should bring in more donors.
Do they publish some information?
Yes, there's an official report on that in Austria.
What about Italy?
Pretty much the same. So we have a monitoring of the brain death, but there is a striking gradient, and it's sad. It's published on the website of the Ministry of Health, but no action, no active action is taken.
Do you know how that is in Lithuania or US? Have you any information about that?
I couldn't speak to it.
I can't speak that as well, but I know, we have only 2 hospitals in Lithuania who actually does the organ transplantation, so...
But many donor hospitals.
Donor hospitals, yeah, so main university hospitals, so it is quite limited, but how is it controlled? I cannot really answer that. That's a good question.
Okay, thank you. A very burning question, otherwise I think we have to finish to move to the last session. Okay, thank you very much for your participation.
Ett, tycker jag, fantastiskt föredrag att vi får höra om den första hjärttransplantationen från gris till människa. Och det kan låta futuristiskt och framtid, och förstås är det. Men redan 1964 så gjordes i USA en transplantation av en schimpansnjure till en patient som fungerade i 9 månader med den tidens väldigt primitiva immunsuppression. Det var några andra transplantat också, men det här var det längsta. På 80-90-talet så var vi där igen. Då var det inte schimpanser. Det ansågs inte möjligt att använda schimpanser. Det var baboons. Och vad det gäller celler var det grisar. En patient i USA levde 70 dagar med en babianlever. Baby Faye, som kanske vår talare kommer att prata om, bebisen, fick en babianhjärta och levde i 17 dagar. Och här på Karolinska så gjorde vi 10 patienter som fick fetala öceller från gris. På 90-talet så fick vi också den första transgena grisen Astrid som togs fram i Cambridge. Just för att möjliggöra transplantation. Vad hände sen? Jo, sen så kom PERV. Porcint endogent retrovirus, ett virus som alltid finns i en gris och som man var rädd skulle orsaka sjukdom hos människa. Och det andra som hände var att vi hade en hype, vi hade en enorm optimism om att stamceller skulle lösa allt. Vi som forskade med grisöceller fick ju höra att varför gör ni det? Stamcellerna kommer att fixa det. Man sa till mig, varför jobbar ni så mycket med organdonation, Håkan? Varför jobbade vi så mycket med det? För snart skulle vi ju hämta njurarna inne på labbet, stamcellerna skulle fixa det. Så xenotransplantation hade en väldigt tynande tillvaro i ett antal år. Det har hänt en del i Asien, men det mest spännande vi har nu, skulle jag säga, det är den transplantation som gjorts i USA, där en patient fick ett grishjärta. And it is my pleasure to introduce Dr. Bartley Griffith, who is professor of surgery at the University of Maryland School of Medicine in the United States. Do you hear us, Bartley?
I do.
Yeah. Well, you're most welcome. While we were getting your Zoom link functioning, I just told a little bit about the early days of xenotransplantation with the 9-month survival of Keith Stremsma's kidney chimpanzee kidney patient and so. But now we really want to hear the latest news from the xenotransplantation of today and what you foresee for tomorrow, please.
Sure. So would you think it'd be best to share a PowerPoint presentation as I speak, or would you like me to be spontaneous?
Well, I didn't get that. Sorry. You want to show your presentation, or do we have the presentation? I don't know.
I can share a screen if you'd like.
Please share a screen. Please do that.
Okay.
I'm sure you have very interesting slides.
Okay.
Let's PowerPoints.
Let's see if we can make that work. Okay.
It looks promising.
Yeah, good.
And maybe you can have a show mode if you will. I think we see it this way also.
Hang on just a second.
Yeah, good. Seems to be the right icon.
Hang on. Let me just get the thing. It needs to come up in a show mode though for you. Hold on. I'm sorry I tried to get on early, but we couldn't connect.
No, okay.
Hang on a minute.
Yeah, we are hanging on. In Sweden, we have a say that the one who waits for something really good can't wait for too long. So we are happy with waiting a little bit.
Fine, thank you.
So.
Now, 1 minute. There we go.
Yeah.
I think that will work.
Yeah, it looks good.
Do you have the full screen?
Yes, we have the full screen. Thank you.
All right, wonderful. Okay, still good? Great. Well, thank you. And it's an interesting era where we can begin to think about the chance for patients who have end-stage organ disease. Kidney and heart seem to be most promising, perhaps pancreatic replacements for diabetes. But patients who have been waiting forever almost for organ replacement will presumably in the next decade be able to begin to have an option to make an opportunity for an appointment to have their heart transplanted, because there will be commercially available suitable organs that we understand better how to keep alive in a patient. Our big event occurred, of course, with David Bennett having an operation in Maryland to replace his heart in early January. Okay, now I'm trying to move on. So this is David Bennett with his physical therapist, shown a few weeks after his surgery, and it shows a lot. It shows that David is up, sitting for the first time in many, many weeks. He's making some progress. His early postoperative course was mired with just inability to do anything, couldn't even hold his head up. So he was quite sick, and I think it's reasonable to say that we were making progress. This event that made people take notice was really quite enthralling for everybody who took care of David. This is a snapshot of one of our ICU rounds with multidisciplinary involvement. This is a big deal. It took us maybe a full year to prepare everybody. And then, of course, everybody's preparedness fell on years and years of training in their specialty, which included infectious disease and cardiology and intensive care and nephrology. But you can see this is a Saturday morning, I think 2 days after his transplant. A lot of people interested and a lot of people really putting their heart to the work. So what did we do and how did it happen? If we were to have sewn a heart from a wild type pig, I mean a pig that has not had any kind of genetic alteration, into David's chest, presumably what would have happened is what's shown on this slide, which is a heart sewn into the abdomen of a baboon on the left. That heart is not altered in any way with the genetic, differencing. And so that heart is shown as quite foreign, and it is reacted to within minutes because we all have pig antibodies in our blood, and they come because they are just part of living with the world. Lots of little viruses have hooks of pig, and we just get exposed to, we eat pigs, pig dander, all kinds of things sensitize us. And most every human will have anti-pig antibodies. And those anti-pig antibodies will cause an immediate reaction that thromboses or clots the blood vessels in the wild-type heart really within minutes. And so this is all based on these preformed antibodies and the deposition of them plus complement, which creates a coagulant mess. So the first thing we had to do in the field was to get around this problem of our presensitization. And that was done principally in our world by Revivicor, a company now in the United States that made 10 genetic edits to the pig heart that we used on David. We took out 4 different genes. 3 of them were critical genes that really had to come out early, and in the science came out, as one of the first genes that were removed. And these were carbohydrate surface genes on the endothelium, and they're kind of known as the GAL family. And we took out 3 of those genes. We also noted in the primarily this experimental kidney work, that kidneys seem to grow, and they continued to grow much bigger in their abdomens of their baboon hosts, such that they actually would get too big for the abdomen. There was a decision made that this was not going to be desirable, and so a knockout was made of a growth control. And so a knockout gene, the 4th knockout, was for that. We placed new genes into our pig, primarily to control complement and coagulation and inflammation. We were able to place a gene to decrease inflammation and to augment really humanoid, if you wish, regulation of thrombosis. We had the temerity to suggest going into a human by translating this early work by my partner, Dr. Mohideen, who's shown here with a big hug from me. Dr. Mohideen has spent much of his life trying to answer this goal of human parts or animal parts for humans. And this shows one of his patients at the National Institute of Health. This is a baboon who has had a non-working heart placed within its abdomen. The heart was connected to the aorta for blood supply, and its drainage was to the inferior vena cava. Blood circulated through the vascular system, but not really through the organ as a pumping heart. This animal you can see is at day 784. He was able to have animals as long as 3 years under stringent control and immune suppression. Interestingly enough, when he stopped his immune suppression, the animal's heart stopped beating almost within 2 weeks. So there was no evidence of tolerance in this work. But the fact that he had a whole series of animals like this caused us to recruit Dr. Mohideen to our center, because we thought it was time to take the heart out of the abdomen and place it within the chest so that it could be really a pre-human type. What Dr. Mohideen showed was not just, an interesting video of an abdomen that was pulsating as if it had a heart, but also the type of immune suppression necessary to keep the xenograft in an edited heart working. The gene edits aren't perfect. We don't know how to correct all reaction against it, and so an amount of immune suppression is necessary, just as it is in human heart transplantation. In this case, the key to the better outcomes seemed to be the use of an antibody called anti-CD40. And not to make any of you immunologists, but this is an antibody that hits B cells that create antibody-mediated rejection. And it appears that allorejection, which is more cellular in its response, the T cells, is very different than xenotransplantation. in which the B cells seem to attack the organ. So it was natural to take on the B cell and suppress its activity, and that's what was achieved with the anti-CD40 drug. Here is a picture on the left of one of our current experiments, which shows a fresh and just transplanted pig heart in the chest of a small baboon. Now, this baboon weighed about 22 kilograms, and the pig, I think, was about 23 kilograms. And that's the heart. You can see the lung ventilating in the upper portion of that. But that's what it looks like. And we were doing very well with early results, i.e. within 8 hours, the hearts seemed to squeeze very well. But after a short period of time, these hearts seemed to literally poop out or run out of gas. And the picture on the right is a typical picture of our baboon ICU, which shows all kinds of medication going into that baboon to keep the heart going. Well, that wasn't a really good outcome, whereas, you need the baboon heart to work for longer. And we were pretty sure that the animal was not rejecting. So we couldn't unlock the secret as to how to translate taking the heart out of the pig, keeping it cool, and then sewing it into the baboon. Our outcomes were dismal in many ways, even though we were using this very sophisticated genetically deleted animal. And this is interesting, in my mind anyhow. We were working between 2017, and I think, let me move my little thing here. This date, you can see it, I can't, okay, is between 11/17 and 8/19. During that period of time, we only were able to do 16 cases, which is a lot, more than any other center was doing at the time, of course, because the cases are very expensive. They cost about $750,000 each. And that's because the gene-edited heart is expensive to produce, and of course the work in non-human primates is very expensive. So for our total output of $12.7 million, only 3 of 16 of these animals survived for greater than 2 days. We were pretty upset and almost ready to give up. Then we discovered this. And as shown on the first slide, this is the heart of a pig that's being lowered into a bucket, if you wish, that's hooked up to a system called ex vivo. And ex vivo prepares a solution that's made part from red blood cells that we add, but also into which is albumin and electrolytes and even some hormones, including cocaine in the perfusate. And that heart is not kept only in ice. It is actually perfused with this perfusate on a continuous basis until it's removed and sewn into an animal. We learned from this from Bruno Reichart, the fine surgeon from Munich, whose team had just presented survival rates which were fantastic at the time. This was a report that came as a letter, and it was really devastating to us in that they were doing so much better than us, but we learned from them how they did it. And one very important part of the paper explained the use of this ex vivo type system to keep their animals' donor hearts strong once they were implanted. They had run into the same problem of the hearts not treated this way as pooping out in about 24 or 48 hours. So once we got on and going, we learned from this, and then we made our way actually to Sweden. We went to Inglosia, to Professor Steen's complex, where we learned how to use the ex vivo system. And we very quickly used this in our protocol, both for our animals and then to justify the use in humans. Well, now we'll switch to our first case. And this is a story about a man who had no other outcomes in our mind. He was in the hospital for 61 days. He had been refused heart transplantation primarily because of his frailty. And you can see his lower leg is shown on the left with my fingers trying to span across, which is almost complete. I have a medium-sized hand. You can see his chest wall after surgery is very, very thin, and it's what the nutritionists call striking sarcopenia. During his hospitalization, we learned that he was not very good at taking care of himself, and he had failed to take care of his instructions from his heart failure doctors. He was described as being the worst patient this doctor had ever had in terms of his compliance and willingness to come back for medical care. We thought that we could take care of him. We would send a team to his house if necessary, and that this experimental transplantation could possibly provide him an opportunity for life. He never stopped wanting a human heart, but he was very clear in his mind that he accepted the experimental transplant. He said if he didn't live long, he hoped that we would learn something, and we certainly have. The other thing about his overall care was he was supported on VA ECMO for almost 50 days before the surgery, and he seemed to have a reduction in the overall robustness of his bone marrow, in that his white blood cell count averaged about 3.2, but many times dropped quite lower. His platelet count was 90,000 on the preoperative laboratory tests. We would normally perhaps have turned him down for any therapy in our center without the opportunity of offering this experimental transplant, just on the basis of him being too sick to benefit from anything. So the fact that we gave him an opportunity, he moved forward and he lived 60 days, is actually what we consider to be a success. And we've learned an awful lot. This was how well his heart, or how well his heart did not contract before surgery. He had a almost 10 centimeter dimension to that heart preoperatively. His immune suppression, as I mentioned to you, was unique amongst all that we've given, and I've given immune suppression for heart transplantation for more than 40 years. So the uniqueness was this anti-CD40 drug shown on the stack of drugs here on the left. We also used rituximab to reduce his B cells. That's an anti-CD20 drug. We used anti-thymocyte globulin. And then after surgery, we just gave him the anti-CD40 and the MMF to 500 milligrams twice daily and a low dose of steroids. So that wasn't too tough. You can see that before surgery, he had T cells and B cells kind of in the normal level. And after his surgery, we were able to knock them down because of this induction therapy. If you look up here, you can see flow analysis of his T cells. And the T cells are shown in this quadrant right here. And over time, this is day 0, day 1, and day 3, there were no T cells in his circulating blood. The other big part about his problem would be knocking down his human non-gal anti-pig antibodies, which we had to do because, again, I told you we all have them. And those antibodies were reduced with our treatment. Primarily, the rituximab therapy took care of that for us. The growth-retarded pigs, because of the gene knockout, are interesting. They tend to grow slower, and they don't get quite as big as the 400-pound usual wild-type pig. And what we learned, almost with a disaster in place, we learned that their heart is even smaller than their body weight would suggest it might be. Our pig was 110 kilograms, and our patient was about 70 kilograms in weight when we operated upon him. The pig heart looked rather small. We were comforted by the fact that the stroke volume by echo in the pig suggested 40 mLs per minute. But we were a little bit upset by noticing in our patient that had mitral valve regurgitation that his left atrium was so large, as I mentioned, is over 8 centimeter left atrium plus left ventricle. But the connection of the left atrium to the left atrium took a little bit of surgical skill. And in fact, I was glad that it wasn't my first heart transplant. Once we were able to align the atria and move things forward, we completed the surgery. We did not do the traditional connection of IVC and SVC to the donor. We had to use the donor's right atrium. And literally move it to the left to make the connection, because the very leftward and large left atrial connection moved our donor heart way into the left side, and we really had to bring, in essence, the host right atrium over to it. You can see in this picture, this is a CT scan post-operatively of Dave. This is his large remnant of left atrium. That 85 millimeter spanning arrow is the residual host left atrium, and that 25 millimeter area is the connection that we made to the small donor left atrium. And that's as good as we could do. The right-sided connection is shown also to be a little unusual, with a small connection, but one that didn't obstruct inflow. But we were worried about that. It was more of a challenge than I thought it would be at the day of surgery. This is a strain echocardiogram, which is the best way I can tell you that for most of the course of David's post-operative 60 days, his heart performed literally like a rock star. It's squeezing just beautifully, and you can see how well it not only squeezes, but it relaxes very well. So there was no evidence of systolic nor diastolic heart failure throughout the course of his therapy until he got sick after 43 days. His first biopsy is shown here. Those of you who've looked at heart biopsies after transplant would know that this looks almost normal. There was not one inflammatory cell out of place. This was on day 32. There was no evidence of antibody-mediated rejection and no rejection whatsoever. It just simply looked like a normal heart. And we were ecstatic when we found this. He had lots of troubles after surgery, as you might expect, because he'd been so sick. He developed a peritonitis and a rebound. The surgeons felt that perhaps there was a problem within his intestinal cavity, a perforation perhaps, something of that nature, and they performed an exploratory laparotomy. They did not find a perforation, but they did find putrid pus all over the abdomen, and they washed it out twice. Never found a hole in anything, but quite clearly he had had some type of an ischemic bowel process, probably from the period around his surgery. It became a little more complicated after his very clean biopsy, which is shown as the number 1 up there. The number 2 is our second biopsy, and that occurred about 10 days after he became sick again. This time his illness seemed to be not from infection in the abdomen or something like that, but he appeared to be, as we say, septic. He seemed to be not failing from his heart, but really it looked like he had an infection in his blood. We gathered on a Saturday morning when he kind of turned from looking great on Friday to Saturday, and we noted that his blood was containing very low infection-fighting immunoglobulin. His level was 187. It should be over 1,000. And so we gave him IVIG, and we changed his antibiotics and antifungal and antiviral therapy. At the same time, after this happened, we were able to go back and look at his anti-pig antibodies, which we couldn't get on a daily basis. It took about a week to get each of those red circles and red squares and blue circles to be tabulated. But post hoc, we were able to show that around this time of this kind of sepsis appearance, there was beginning to be a rise in the IgG and the IgM, and also in the green levels there, which were simply the enzyme that would leak from a heart that was being injured. In spite of the fact that we didn't have any evidence of heart being injured, we were beginning to detect something in the blood that said perhaps you have a little heart injury going on around the time of sepsis. And those of you who take care of sick patients know that there's a myocardial depression, an injury factor that occurs with sepsis, and we felt perhaps that's what we were dealing with. Consistent with something going on back there in the same day 42, we found a preceding rise in cytokines that are of the nature that kind of go along with an infection or some type of septic process. The Th1 cytokines, which are pro-inflammatory, were elevated just at about the same time. So clearly we had something we didn't understand We gave him the IVIG, knowing that IVIG comes from a pooled sample of humans, and that humans carry anti-pig antibodies. So in some ways, some of that rise in the IgG and IgM that we're seeing here could have been based on the treatment that he received for his low circulating immunoglobulin numbers. All of this, was kind of in the fog of taking care of a patient, and we just weren't sure. Then we came along. He seemed to get better. He was sitting in a chair, and then overnight, he got really sick. He seemed to get past the day 42 problem, got through it. He was sitting in a chair. We were talking about maybe even going home. He was that good, and then the bottom fell out. I saw him in the morning. His ears turned kind of bluish, tip of his nose turned blue, and he was clearly in a low cardiac output state. We thought perhaps at this point we were facing not sepsis, but maybe an acute rejection. So we began to try to take some of those antibodies that we were now able to detect out of his blood to see if we could help reverse what might be a looming and maybe irreversible antibody-mediated rejection. In the end, what we determined was his heart became very, very thick. And there's an autopsy section of his heart. It looks like the pit of an olive, really, not like a heart that you would expect, with a nice muscular wall, but a very large cavity for filling and for function. So this heart had swollen overnight, much as though, it was like an ankle that had been sprained, on a curb of a street and blew up instantly. It was quite alarming how quickly his heart went from normal to that very thickened state. The echo on the left was a pre-echo before he got into this jam. It's shown as what we call a cross-table axis, where you can see the left ventricle squeezing as a circle, as a donut on the lower portion, and the right ventricle is wrapped over the left ventricle above, and they're both squeezing really well. When he entered into this problem, which I called, his swollen ankle type swelling of the heart overnight, you can see how thick the walls of the heart are. And while they're squeezing, they're not able to relax. When we mapped the change in his heart's thickness, you can see by this graph, which shows the interventricular systolic dimension and the posterior left ventricular wall dimension. Both of those measurements show a rather dramatic increase in the thickness of his ventricle. This was not growth. This had something very more ominous about it. We did a biopsy during this period, and at the 50-day, the endomyocardial biopsy still looks pretty good. The muscle doesn't show any inflammatory process. We looked for the presence of complement on the blood vessels and found none, which is almost necessary if you're going to suggest that this was rejection. We did find in the interstitium of the cell of the muscle of the biopsy not inflammatory cells, but we found red cells that were free floating. They were extravasating from the capillaries into the myocardium, along with the edema. There was no thrombosis in the blood vessels and very, very little what we call inflammation. We were stuck. We weren't sure what was going on. We had an inkling that perhaps we had a problem that nobody expected. This is a graph which shows a cell-free DNA of human cell, of porcine cell, and of a virus that we call PCMV. All of us circulate some free DNA. As our cells break down in our body, the DNA gets released and the blood carries a certain amount of it. You can see in this blue that the human DNA was dominant throughout the course, as one would suspect it should be in anybody. But we were able to detect porcine cells. So that, porcine DNA looks different, and this analysis, which was done by Carius, was able to detect the presence of porcine cells. Well, that's okay, because the heart, has cells that flake off, and, part of having a vital organ is some of those cells will slough into the red blood into the body, and you can detect it on a very, very sensitive scan. So we detected parts of DNA from the pig in the blood, But the green one was the one that got us concerned, because the green line shows the presence of snippets of DNA known to be present in the virus PCMV, and that virus would have had to have been part of the donor heart that we transplanted into Dave Bennett. We had done 4 qualifying tests, all nasal swabs with PCR, to eliminate any suggestion that that was possible. The donor heart was declared free of that virus before we put it into Dave. What we learned was, in post hoc, that very sensitive PCR was not sensitive enough to exclude it from the pigs. And we actually transplanted a virus in a latent phase into David. And the latent phase PCMV seems to be reasonably latent for most of his course until he got really sick. And then you can see that more and more viral DNA is being detected in the blood. And in fact, there's more viral DNA in the blood than there is pig DNA towards the end of his course, which suggests perhaps there may be a suggestion that the virus is not only just being shed as part of the injury to the heart, but it's being shed in a replicating form, in that more virus is being produced. I think it's best to also then move to the fact that when we looked at those good-looking biopsies where we didn't see rejection, did we find any virus? Well, using in situ hybridization techniques, we were able to identify PCMV virus, and the best-looking one is shown right up there in the upper right corner. And there are lots of little nuggets of viral RNA in that cell, suggesting that it was a very active cell. That's not the only reason we think perhaps this was a virus that had become active. We were able to identify RNA transcripts from the heart of the donor at autopsy, which demonstrated that the RNA was carrying what's considered to be transcripts of activation. And these 3 columns are different RNA groupings which go along with an activated virus. Again, if you look at the upper column of really high power resolution microscopy, you see good-looking endothelial cells all across, except the last one of the 3, which shows the capillaries seems to have, in time, become totally lysed. The 2 on the left are earlier biopsy examples, and on the right is an example at the autopsy where we saw a whole lot of capillary beds that seemed to be lysed, without any evidence of any inflammation with thrombus or platelets. They just seemed to lyse. Well, knowing that the virus lives in the epithelium of the capillaries, or the endothelium of the capillaries, we began to think that its activation caused lysis of capillaries and then led to the heart swelling, which was rather bland, except for the red blood cells, and then ultimately David's death from diastolic heart failure. If we had been able to identify a virus, it would have looked like the one in the lower left. Lower left shows with the yellow arrow. That's what we would have seen if we had detected the virus in the magnified histology. We didn't find any virus by those techniques. It took in situ hybridization to get it. So, in the end, we're still digging for a cause of the loss of David. We do believe that it was likely related to the presence of the virus, but we can't exclude an odd form of acute antibody-mediated rejection. We don't know the role of the IVIG that we gave. We have qualified new screening tools to eliminate the risk of transplanting another heart with a virus. And it also makes us double down on the donor care, because that virus can be transferred in a herd very quickly. We are approaching the FDA to continue our experiment to permit another patient perhaps to benefit from this surgery. So that's a lot to say, but a lot happened in 60 days.
Thank you so much. For sharing with us your experience of this historical case. Truly, truly historical. Do we have some questions from the floor for Professor Bartlett? I do wonder, do we have the optimal pig now? Or is it a good enough pig?
Very good question. We don't know. I think we have as good a pig as we're going to get for a while. Understand that we only changed 10 genes, out of 30,000. But every time a gene is changed, it can change the animal for the worse. The removal of a certain gene that seemed like a good idea turns out to be a terrible idea. This gene editing has been going on since the mid-90s. And you might imagine it's remarkably expensive. And do these tests, they're not like rats where, you can do 10 of each in an afternoon. That's a whole year's worth of work, 10 experiments. So it's going to be very labor intensive and drawn out. I think it's good enough right now to move on and to continue to work. There may be a better pig, not much different than, what we have now down the road, in a few years. But I think this pig is good enough to continue the experiment.
We have another question, please.
It's not. Now it's working. Hello, Dr. Griffith. Andreas Zuckermann from Vienna.
Hi.
Hi. Good to hear you again and see you again. Yes, I'm very intrigued. What is your opinion on if we move to the human as a next step again? What would be the patient population that you would approach first? So in a phase 1 trial, who would be the patients that you would offer a xenotransplant based on the experience you had with the first case?
Yeah, the first case, makes us very cautious to think we could compete with a patient's treatment that would include either heart transplantation using a human heart or even left ventricular mechanical circulatory support device. So the patient needs to be a little less sick, but not too much less sick than this patient, and a patient that really can't be included in either one of those traditional therapies for one reason or another. I think we're beginning to look at patients who are a bit old, perhaps for a human heart transplant, and for whatever reason or not, aren't good candidates for an LVAD. And when you go through your multidisciplinary group's decision-making for allocation of heart transplantation and VAD, you end up with a very small number of patients at the end of the day that might qualify for this type of a procedure at its current, its current level of understanding. I hope, we can do a number of reasonable candidates, of all different type for one reason or another that couldn't have either of those two applications. That might give us enough, information that we learn that we could then construct a trial, a little bit like the LVAD trial that went, against human heart transplantation.
In your opinion, will this pig, the way it's modified, be used for other organs in patients?
Most certainly it will. I think that the major target is kidney.
Yeah.
And I think that we will see kidney xenotransplantation spring forward, just like heart transplant.
Would you, as a final question, like to give us the latest update on the PERV that almost killed the field in the 1990s?
Yeah, luckily I think that we have, our pig has bred PERV C out, and it seems that you need a combination of C being in the system in order to create infectivity to humans. There hasn't been anybody in the pig business, right, who works with pigs or who, has been in the pig laboratories, working, in medical research, who has ever contracted a PERV. That we know. It doesn't make us comfortable, right? That everything is perfect. One of the companies working in the field, eGenesis, has eliminated all PERV from its animals, but it has done that with a massive amount of editing, right? And so when you do all the extra editing to get that done, you have the potential to change the organ or the animal for the worse. And so we have to, be sure it hasn't affected breeding and things like that.
Well, we also had all those patients being given pig insulin in the old days, and we don't really know whether that was PERV-free either. We have a last question, because now Professor Bo-Göran Ericzon would like to ask a final question.
Yeah. Thank you, Dr. Griffith, for a nice presentation, and congratulations. I have a question related to these pig organs. I mean, normally the organs are not isolated, but they communicate with other organs in the body. What do we know about how a pig organ, like a heart or a kidney, can communicate and understand the information that is sent from other organs, telling the kidney how much to make urine or the heart to move?
Yeah, it's really interesting. I thought you were still on the infectious disease side of this, and thank goodness we have a physiologist in the crowd. Because in fact, we did see PCMV in the other organs after it activated in Dave, but none of it seemed to infect any of the human organs, by the way. So the PCMV only infected the donor heart, and that's why we ran into trouble. None of the other human organs had any inflammation associated with the presence of that virus. Now, how did this heart work? The pig heart is close to human. It's a little thicker in general. It tends to run with a lower blood pressure in a pig. So, and our German colleagues have felt that when the pig heart is put into an animal or a human that runs a higher blood pressure, that will create a little bit of a hypertrophy issue. And I don't think they're wrong. I think they're absolutely correct. So there is definitely a difference. This heart worked great. It was on the smallish side for this patient, but he ran a pulse rate of about 100 most of the time. He had no evidence of low cardiac output. His mixed venous saturation was terrific, and his right heart catheterization showed low filling pressures. We were worried about our anastomoses. Were they too tight, across the atria? They never showed to be a problem. So I think intrinsically the heart can work. I think we're going to have to learn how to take care of it, just like we have to learn how to take care of human hearts.
Thank you so much. We have one more question from the floor.
Hi, Professor Griffiths. This is Ina Laura Perkins, CEO of Real Heart. I have a question because in the US also the Syncardia artificial heart is available. So was this an option for the patient? And if not, why not?
Good question. I mean, you can totally obliterate progress by saying we have an answer for everything already, right? The total artificial heart status in the US is uncertain. And it's, in most surgeons' mind, rather unproven in terms of benefit. Fantastic new opportunities may be evolving both in the US and in your wonderful experience. We can't wait to see the Real Heart. Thank you for sharing some of those wonderful thoughts with me before the meeting. I think what you're doing is fantastic. I think, if we can have a mechanical substitute, for the human heart, everybody wins. I think we want to go down both pathways in parallel. We did not offer the total artificial heart to Mr. Bennett for a couple of reasons. He didn't want it. He did not want two hoses, coming out of his chest, because that's a pneumatic heart. And we have not been very successful in its application at the University of Maryland. I put my first total artificial heart in a patient in 1985. So I know that business pretty well, and I respect it greatly. It was a Jarvik heart. But I just think that ship had sailed at our center. We also offered him out to two regional centers and then two national heart transplant centers, all of whom have, mechanical support options. And they all turned him down for being too frail.
Sir Roy Carl in UK used to say, when we were talking about innovative methods, about xenotransplantation, also about cell transplantations, that xenotransplantation is just around the corner. The problem is that it's been there for some decades. But now I think we are moving closer. We are moving closer to the corner, and we would like to thank you so much for sharing your experiences with us in such a transparent and detailed way. This was a very interesting lecture, not least for me, who's been involved in xenotransplantation very much in the 1990s. So I think a big applause again for this historical case.
Thank you so much. It's an honor to be part of it. Thank you.
Thank you.
And thank you, Annika, for taking care of this session. And I really, really would like to thank you all for being here today. Swedish First Transplantation Forum. We have had really good speakers, don't you think? Hopefully this is not going to be the last Transplantation Forum. It's just a start, isn't it? Yeah. And I would like to end by, I saw this T-shirt by the Viking stand, and I think this is so good, and you've probably seen it many times, but I do think it's good. Don't take your organs to heaven. Heaven knows we need them down here. And I have a friend who is a musician, and he didn't think it of the same way that we does. Oh, God, no. We need all the organs we can get in Sweden. Organs, you know. Yeah. So, I hope we all will continue to work for more organ donors. Soon it will be the annual Organ Donor Week. We can do all we can to promote the opportunity and take a stand for being an organ donor by registry, of course, at donationsregistret.se. Yes? So thank you all for being here, for taking care of this very, very broad and very important area to discuss further on and take it home with you. And you can also watch these sessions on our Focus Patient YouTube channel in some weeks. So take good care and travel carefully as well. Thank you for today.